Complications of diabetes. Mismanaged diabetes puts the patient at risk of developing dangerous complications. Cardiovascular complications, myocardial infarction, stroke, and CHF. From premature atherosclerotic disease, all significant risk. BP colon in those who diabetes with diabetes at least less than 140 by 90 million mercury. Diabetes is considered an equivalent of coronary disease for treatment of LDL, and goal is less than 100 mg per liter when initiating treatment with statin. Diabetic nephropathy, early in the disease, macroalbuminuria may develop, that is, albumin 30 to 300 mg per 24 hours. Dipstick for urine becomes trace positive at 300 mg of protein per 24 hours. Screening recommendation for those with diabetes is iron testing for macroalbuminuria, present ACE inhibitor or ARB when it is present. These agents are proven to decrease the rate of progression of nephropathy by decreasing intraglomerular hypertension and decreasing damage to the kidney. Gastroparesis and immobility of the bowels. Over several years, diabetes mellitus decreases the ability of the gut to sense the stretch of the walls of the bowel. Such is the main stimulant to gastric motility. Symptoms include bloating, constipation, early satiety, vomiting, and abdominal discomfort. Treatment is metoclopramide or erythromycin, which increases gastric motility and no response to the gastric pacemaker. Retinopathy, diabetes mellitus effect on the macrovasculature is especially apparent in the eye. In the US, nearly 25,000 people go blind from diabetes each year. The only treatment for non-proliferative retinopathy is tighter control of glucose. Aspirin does not help retinopathy. When neovascularization and vitreous hemorrhage are present, it is called proliferative retinopathy. This is treated with laser photocoagulation, which markedly retards the progression to blindness. VEGF inhibitors that treat severe retinopathy. Retinopathy is vascular endothelial growth factor. VEGF inhibitors help. Neuropathy, damage to macrovasculature, damages the vessel nervorum that surrounds large peripheral nerves. This leads to decreased sensitivity in the feet, the main cause of skin ulcers of the feet, which leads to osteomyelitis. When the neuropathy leads to pain, treatment is with pregabalin, gabapentin, or tricyclic antidepressants. Hypoglycemia. The most common reason for hospital admission in diabetes is hypoglycemia, not DKA or new onset diabetes. The most common cause is error in treatment. Example, excess medication or inappropriate dose adjustment, particularly as renal insufficiency decreases insulin requirements. Treat by giving glucose and or glucagon either intravenously or by inhalation. Other causes of hypoglycemia are insulinoma, low glucose plus high insulin plus C-peptide removed less surgically. Insulin autoimmune antibodies or antibodies present. Sulfonylurea abuse, urine metabolites of sulfonylureas found, elevated C-peptide and proinsulin. Surreptitious use of insulin / suicide, low C-peptide, low proinsulin. Hormone-related conditions. Hirsutism. Hirsutism is male pattern hair growth in women. It can develop from any of several causes. Medications, minoxidil, valproic acid, penetrine. Emotional distress like depression. Polycystic ovarian syndrome. Cushing's syndrome, adrenal hyperplasia, androgen medication use, androgen secreting tumor or carcinoma. Fertilization is more severe than hirsutism. Symptoms include clitoromegaly, deepening of the voice, irregular menstrual periods, acne, and increased muscle mass. Testing should be done when patients present with irregular menstrual periods and signs of virilization. Prolactin, DHEA, testosterone, FSH/LH, synthene hydroxyprogesterone. Manage hirsutism with oral contraceptives, antiandrogens, spironolactone, finasteride, metformin, only in polycystic ovarian syndrome. Polycystic ovarian syndrome. Polycystic ovarian syndrome is the most common cause of oligomenorrhea in the US, with dramatically high incidence that is increasing. The following criteria used to diagnose PCOS: clinical hirsutism and or high testosterone DHEA, irregular menstruation, 10 cysts on pelvic sonogram with enlarged ovary greater than 10 cm. The US requires only 2 of these criteria. The idea that a pelvic sonogram is required to establish diagnosis is a common error. If the patient meets the other two criteria, sonogram is not needed. Also note that LH/FSH ratio is not part of the diagnostic criteria. Treatment of polycystic ovarian syndrome is a multi-system approach. PCOS is a pre-diabetic state. Some of the same mechanisms that cause insulin resistance also interfere with aromatase or aromatization of testosterone to estrogen, leading to higher androgen levels in these patients. LH/FSH alterations occur afterwards. Metabolic health is very important in these patients, so BP, lipids, glucose, and weight must all be followed diligently and managed. Irregular menstruation is a problem in PCOS because a woman's uterine lining must be shed regularly. Otherwise, there may be a conversion to uterine hyperplasia pre malignant. Treatment is oral contraceptive pills containing progesterone to regulate menstruation, spironolactone, last line for pain or hirsutism, but only after lifestyle management, metformin, and oral contraceptive pills have been tried.